Hello, and welcome to the Imaging Wire Show. My name is Brian Casey. I'm managing editor of the Imaging Wire. We've got a great episode for you today. We're going to be talking about new solutions for osteoporosis detection. And we've really got a great panel of guests here today. Our guests are Dr. Morteza Naghavi. He's a physician inventor and founder of HeartLung Technologies. Dr. David Yankelevitz. Dr. Yankelevitz is a pioneer in lung cancer screening and is a professor of radiology at Mount Sinai Hospital in New York. He's also co-founder of the International Early Lung Cancer Action Program, or ILCAP. We also have with us Dr. Claudia Henschke. She is also a pioneer in lung cancer screening and is a co-founder of ILCAP and a professor of radiology at Mount Sinai Hospital. And we have with us Dr. Thomas Atlas, a diagnostic radiologist and owner of Tustin Teleradiology in California. And we have with us Anthony Reeves, PhD. He is a professor of electrical and computer engineering at Cornell University and a leader in AI-enabled automated lung and cardiac CT. Thanks everybody for being with us today.
Thanks for having us.
You bet. So let's start with introductions. Dr. Naghavi, can you go first and tell us about HeartLung and your role at the company?
Sure. I'm Morteza Naghavi. I'm the founder of HeartLung, the company that has a unique collection of brains from cardiology, radiology, pulmonology, and computer science engineers in one place. That's a unique cross bridge that we've created, and we refer to our group as united by one thing, a chest CT scan. And this primarily, I give credit to Dr. Henschke and Dr. Yankelevitz for their work, and Dr. Reeves for their work on early detection of calcification in lung cancer screening, which they started. They kind of bridged to our world, cardiology, where I am primarily trained in. And then our interaction resulted in building what now you see as a whole set of AI solutions to bring those to preventive imaging. And if I just jump over the next 10 years, we envision that this effort could change the preventive medicine for decades to come, because now we have a tool that can be integrated in primary prevention of diseases, not just lung cancer, not just heart disease, not just osteoporosis, but diseases that could be detected early by a chest CT, low-dose chest CT scan, say at age around 40, and repeated over time. So HeartLung's mission is to bring that vision to patient care, early detection for years to come.
Very good, and it's such an important topic. Dr. Yankelevitz, can you tell us a little bit about you and your work?
Sure. First, thanks for having us here. I'm David Yankelevitz. I am a thoracic radiologist over at Mount Sinai. With Claudia Henschke, we started the ILCAP program back in 1992. Actually, back then it was the LCAP program. It became the international program over time. And we've been very interested in how we can go beyond just lung cancer screening. Initially, it started as lung cancer, but we recognized early on that we're seeing so much more. The challenge was how to do this. And the tools really weren't there. We recognized we could report calcium scoring based on visual scoring systems, and we made a visual score, emphysema. Eventually, we got into looking at the liver and osteoporosis, but we had no real tools to integrate this. Now, with what HeartLung is doing, we've really seen the potential for how all of these illnesses can be integrated under one umbrella. And as Mort said, I think we're at the dawn of a new era of preventive health.
Yeah, it's very exciting. Dr. Henschke, how about you?
Well, I think smokers and smokers are at risk of all sorts of diseases. Actually, bigger killers are cardiovascular disease, but osteoporosis is an important finding, because if you find that early, just like we showed that if you find lung cancer early, you can cure it. But if you find osteoporosis early, you can stop the progression, or you can mitigate the progression and prevent a lot of fatal fractures or disabilities. So it's a very important additional finding that you can make.
Yeah, definitely. Dr. Atlas, how about you?
Part of a radiology practice based in Tustin, and part of the work includes lung cancer screening and the coronary artery calcium screening, with the eligible patients oftentimes opting for the AutoBMD to rule out osteoporosis. Looking at roughly 3,000 we've processed in the last 2 years, about 90% were completely unaware of the risk of osteoporosis and had never been screened, even though they were all eligible. So it just kind of shows how many people aren't getting screened.
Yeah, for sure. Dr. Reeves, how about you?
Yes, I'm an engineer in this group that I've been working with Dr. Henschke and Yankelevitz for over 2 decades, and the lung cancer area. And in that arena, so there are a lot of other diseases that are measurable. My research was focused on taking detailed measurements from the CT images. And now with the modern advances in AI, this can be done so much more quickly, so much more precisely, that this has come into what we are now doing in the heart, the lung, and osteoporosis too, just as one of many targets that are available in the chest CT.
Yeah, it's a really exciting time. So let's dive right into it. Dr. Naghavi, so we've talking about osteoporosis, and we're talking about opportunistic screening. Can you maybe give us a little bit of an overview of the issue of osteoporosis? I mean, we all kind of know what it is, but the challenges in detecting it. I mean, traditionally we've used DEXA as a tool for that, but that's got its shortcomings of its own. Why do you feel like we need something different to do with detecting osteoporosis?
Well, as you said, the problem is widely known. Let's start with basic statistics. According to CDC, less than 20% of those who are recommended to get osteoporosis screening using DEXA or other modalities are getting screened. So just right off the bat, 80% of the target population are not getting what's recommended for them. Now, let's leave the recommendation aside for a second, because that recommendation by itself is also a late start. You wait till people have serious osteoporosis after age 65 and 70, try to detect them. If you had an earlier way to detect them, which would not have X-ray, and radiation exposure, that guideline would have probably been differently done. But just leave that aside. With the existing guidelines, we're less than 20% adoption. So that's just speaks for everything, that we need a new solution. We need to do something about it. The value of opportunistic osteoporosis screening is just screaming, clear, loud. You already have a scan done for other reasons, be it a cardiac calcium scan or a lung cancer screening scan or a lung diagnostic for any other reasons, or an abdomen scan. You already have done the scan for other reason, and they do have the information for evaluating bone density. In fact, that information, which is 3D in a CT scan, is much more sensitive to detection of osteoporosis than a 2D, which is DEXA. So you have the information, you have the problem. What is the challenge? The challenge is the ability to execute on this and create the tool to make the measurement easy, to make it reproducible, to make it operator independent, and to make it actionable. So that's what HeartLung came in. As you can see behind me, we have a number of AI-generated biomarkers to go after. actionable biomarkers. We decided to start with osteoporosis screening, our AutoBMD, because it was the lowest hanging fruit. It already had U.S. Preventive Task Force Services recommendation as a screening. It already has the problem of less than 80% or more than 80% are not getting treated, less than 20% are getting scanned. And then the information is out there. Chest CT and abdominal CT is out there. So it was just a low-hanging fruit to go for, and we were able to get FDA clearance for this. To our knowledge, we're the first FDA-cleared AI that has the indication of opportunistic screening for bone density, and so could be substituted for DEXA as.
And so how does AutoBMD AI work? Are you basically taking these scans that are acquired for lung screening or some other purpose and kind of running them through the AI, and then it's flagging things if it detects signs of osteoporosis?
A good question. So the FDA clearance that we have puts our technology for any CT scans that obtain for any reason other than bone density. So you can't just go get from your doctor a prescription for AutoBMD. It has to be done for other reasons, a scan done for other reasons, and the AI applies. So how does the AI work? It's pretty simple. First is identifies the vertebral bodies, spinal bones, and then goes within the spinal body, within the trabecular bone, because there are degenerative calcifications around the cortical bone. You shouldn't combine them with the vertebral trabecular bone, because that's the bone marrow, the dense part that keeps the structure of the bone. So that's the advantage of a 3D CT based versus DEXA, which only has 2D and cannot separate the two. So identifies that, and then does the measurements, and then scales it against a reference population and generates C-score, T-score. So that's pretty much what AutoBMD does on all scans that are done for other reasons.
Yeah. Now, Dr. Atlas, you are using AutoBMD AI in your practice there in California. Can you talk a little bit about kind of how it works and what you've been able to do with it?
Well, the main thing is that we're just trying to catch people that have slipped through the cracks and not gotten screened, because the whole purpose of the preventative program, right, is to catch these things early, before they become irreversible or debilitating. And I think almost everybody has a relative at this point that has either fallen and got a hip fracture, ended up in a nursing home. He has a disaster, right? But people sometimes don't realize that when they're younger. So we just try to educate them. With our model, you can develop relation with the cardiologist or with the primary docs and just say, look, if you send them for a lung screen and we spot that it's female over 65 who's never been tested, can we just run the BMD on them? Because all it really involves is one click. It's the same click that would send it to a reading station to be interpreted. They click to send to have the AutoBMD processed in about a minute or two. You can get the report back. So it fits into the workflow without causing any delays.
Now, as Dr. Naghavi mentioned, less than 20% of guideline recommended patients are undergoing DEXA-based osteoporosis screening. How do you see AutoBMD AI and its opportunistic model as filling that gap with the screening rates for osteoporosis being so low?
Yeah, it is correct. 80% or more probably don't get screened. And I've kind of looked at it and tried to figure out what's kind of holding people back. I think there's a lot of primary care physicians right now that don't offer osteoporosis screening. And it's just because people are so busy, they prioritize more immediate health concerns, particularly cardiologists. You don't really want to hear about osteoporosis if it's going to delay their workflow. But the AutoBMD seems to relieve them of any extra work wasted in scheduling. And it also, they don't have to waste time trying to locate a DEXA scanner, which can be hard to find in some places.
Yeah, whereas CT, I mean, kind of everybody's got a CT scanner somewhere.
And then the other thing we found is that many eligible patients don't even know that they can get screened. It's always surprising how little the average layperson fully understands health, or even understands a little bit. And they don't know the guidelines exist. So the AutoBMD actually provides a real patient-friendly educational video site. They can go on the website, which we can actually direct them to, and it's in common language, and it tells them about osteoporosis, the risks, how they could end up debilitated with a fracture. And so all that kind of fits together and draws them in.
Do you ask them when they get their CT scan? Let's say someone's getting a CT scan for lung screening. Do you ask them, hey, would you mind if we send this over to an osteoporosis screening tool, or do you just kind of do it and then you come back to them after the fact?
Oh yeah, no, we always ask. Yeah,
you always ask,
because there's a small, finite percentage of the population that don't want to know what's wrong with them. But most people want to know. But yeah, we would never do it without asking. We usually, there's two main reasons we'll get it. One, age. We'll just say, have you ever had screening before? Would you like to get it? It's just one click. And the other one is, since we read the cases really quickly, if we see a compression fracture on a male, 55, we'll say, look, you've got this fracture. If you didn't fall, why don't we check your BMD? Because a lot of men end up with osteoporosis. They never know about it. So and these things don't take long. It's less than a minute. You can talk to patients and they'll agree, and you get it done.
And it seems like from the provider's perspective, it's a great way to kind of boost your engagement with the patient. And I'm sure that most people, if you do find something, are really appreciative of the fact that you found something like that.
Yep. Yeah, because it's like a one-stop shop. They can come in, they can check for lung cancers, they check their coronaries, and they get a BMD. And it's just really quick, a couple minutes.
Brian, that part for Dr. Atlas, who's a radiologist and oversees imaging center, has one meaning. For a big hospital system, as you know, has much greater meaning, because then those people would need treatments. And they have endocrine division, and they have orthopedic and spine, and they have all kind of downstream care that they could provide. So opportunity screening for osteoporosis would have significant, we have modeled this, the downstream benefit for the providers are far greater than what would be, and of course, the value for their patients.
Definitely. And then we're not going to get into big public health issues here, or maybe we will a little bit later, but the ability to screen for multiple conditions with one exam just seems to me it makes the whole process way more efficient, and really kind of changes the game a lot in terms of what the efficiency of screening is. Well, let's talk a little bit about the technical side of the software. Dr. Reeves, you're a leading expert in AI and radiology. Can you talk a little bit about kind of what's going on with AutoBMD AI, and maybe what some of the advantages are that it has?
Yes, and in recent years, as AI has developed rapidly, we've now got the ability to take the chest scan and to break it down into the anatomical components, examine each component, and detect disease. And we're doing a lot of work with the really serious diseases in lung and in the heart. And the bone mineral density came as, if you will, low-hanging fruit. Once we got the vertebra and we can get the trabecular bone in the vertebra, then that was comparatively easy calculation compared to some of these other more deadly diseases. And so this was like a first step for us to get that and to get it on the agenda for FDA approval. So from technical viewpoint, this was not really hard. It just hadn't been done before, and made so easy for now the radiologists to just say, press a button and there it is. They don't have to go and measure these regions, which is what they'd have had to done previously, which would have been quite labor intensive. Now that just pops out automatically, and they can decide what to do with it.
Yeah. So Dr. Atlas talked about some of the advantages in terms of efficiency and workflow at a practice in terms of being able to offer, opportunistic screening with AutoBMD AI. What are some of the technical advantages that it might have over traditional DEXA scans?
Well, the baseline advantage is it is maybe the CT scanner is a little bit more expensive in the get-go because it's a 3D technology compared to DEXA, which kind of like a chest spray is a 2D technology. But if you use, this patient has already had the radiation dose, has already acquired the image, then it's just a simple argument to say, well, why don't we use that? There's no need now to go and get a DEXA in addition to that. So economical, certainly in the opportunistic sense.
Yeah, and well, the radiation dose is a really interesting perspective because there's been so much attention being paid to that recently, and the more that we can reduce radiation dose, the better. Let's shift over to Dr. Henschke and Dr. Yankelevitz. So you performed this pioneering work with ILCAP on CT lung cancer screening, but as you mentioned, Dr. Henschke, earlier, you were finding out that there was a lot of data that you were acquiring in the process of doing these scans on other conditions. Can you kind of elaborate on that a little bit and maybe talk about what some of the value that opportunistic screening and screening with AutoBMD AI might bring to healthcare?
Absolutely. We found that certainly you see all the different organs in the lung, the heart, the lungs themselves, but you see the bone structure from the neck down to the upper abdomen. And we provided assessment of osteoporosis, but it's a very imprecise determination. Whereas with this AutoBMD, you have precise calculations of every vertebral body that is seen, rather than an overall assessment of if there's a fracture or if there's osteopenia. So it gives you much more data on which to really to report on.
And this kind of goes without saying, but this is all quantitative data, correct?
It's all quantitative, whereas before we said visual impressions of osteoporosis. This is quantitative impression, a quantitative statement of exactly how much, and you can assess how it's increased over time.
All right, so Dr. Naghavi, we have here a typical AutoBMD AI report, and so this is what the software generates, correct? Can you walk us through kind of what we're looking at here?
Yes, as Dr. Henschke was referring to, that she looks at these scan with her eyes. She can say sometimes there are, osteopenic, impression in the bone. But as a practitioner and a radiologist, she can't give the patient a Z-score, a T-score, a quantitative report of bone mineral density per vertebra. That's what the AI does. It does it really as fast as you can go up and down with your finger through, mouth going up and down through skin. AI quickly measures them. You can standardize your report. You report 3 vertebra. Here we have 7, 8, and 9 in thoracic, or take as many as you like. And we have data based on a population over 10,000 from Harvard, UCLA, where we are reporting Z-score, T-score. So you get a report very similar for primary care doctors or endocrine doctors, endocrinologists, that would look like a DEXA report. This is similar to a DEXA report, and Z-score, T-score are comparable. And there's guidelines, there is recommendations. So the report is self-explanatory, both for a provider and a patient, and they can take it from there.
Very good. So Dr. Henschke and Dr. Yankelevitz, can you talk a little bit about, in kind of a bigger, broader sense, what you think adding osteoporosis screening to something like CT lung cancer screening, How much value do you think that's going to add to that? And because right now, everything with screening is all about one test. You go in and you get a colorectal cancer test, or you get a breast cancer test, or you get a CT lung test. We're starting to like talk about totally changing that paradigm and getting multiple tests in one visit. How important is that going to be?
I think you've asked the right question. I think that the term opportunistic screening, while we all kind of use it, I think that was the idea that when you could see one other thing, or maybe things at the same time. I think we've moved beyond that. I think the question really should be, are we at this stage where we're doing comprehensive screening? And I think that should be the term that we're using. And so I think what HeartLung is doing is it's really moving into that domain now. We're talking about comprehensive screening. Osteoporosis is part of it, but the heart, all the things that are going on with cardiac that they're doing, with the liver, with predicting diabetes, I think all of this starts to become what we would call comprehensive, because you're looking at virtually all of the major causes of morbidity and mortality all in one test. So I think that's really what's happening here. And I think there's been this theme that's been going on in radiology. It really started probably in about 2000, where it was recognized that maybe we as radiologists have an obligation to start looking for these things that we can quantify. And it's sort of been quietly percolating, but we haven't really been able to do it until recently. We know that we should be looking at, you can't just ignore osteoporosis if you kind of identify it on a scan, but we just don't have the time to really carefully look for it. When we go back at a screening population and look at it, we're seeing more than 20% of the screening patients have osteoporosis, and another 30 or 40% have osteopenia, and it's not being reported at all. So this is just an enormous opportunity.
How many conditions do you think realistically we can screen for with one test, assuming a CT test, in the near future?
For every organ that you visualize, there should be a recommendation, and but the data has to be developed. The AI technology has to identify the different organs. Then what it means to be abnormal has to be defined, and then the consequences of being abnormal have to be defined. We've done that for osteoporosis and for cardiac diseases and for emphysema, but more needs to be done as data emerges.
And it will even move into indices of overall health, not just diseases specific, but actually indices of overall health will start to be developed. You can see so much on this. You can see muscle and quality of muscle and ratios of fat to muscle.
Oh, the muscle. Yeah, the research on muscle composition is also really exciting, being able to use that as a predictive
Absolutely.
tool. Yeah.
That's an important organ in that same CT scan, because most of the big muscles are in that CT scan.
And it's not just the individual. This is where we say it's really comprehensive, because each of these things interact. The body fat, the muscles, the bone density, all of this is interactive. And so what's required is the approach that HeartLung is taking, where they've taken some of the largest databases in the world and are really analyzing them with this view of being comprehensive in terms of not only predicting individual diseases, but how the diseases interact, or the illnesses interact with each other. And I think that's the approach that's coming.
And we have a large database, over 100,000 people that we've screened with long-term for 20, 30 years. So we will learn the consequences of these findings and what a difference it can make if you find it early and take an action. Even exercise is important.
Yeah, for sure.
And you
for
said
sure.
how many, so you can count here behind me in the circle 10 of those we've identified. And as Dr. Henschke said, we have FDA clearance for the bone density osteoporosis screening and for cardiac chambers analysis. Those two are already cleared. The others, 8, are coming. We hope that we get those all cleared over the next year or so. And the reference that Dr. Yankelevitz said, that comprehensive health screening this is something that we discussed in our conference last September, the first conference on integrating early detection of heart and lung disease. And that conference concluded that eventually, again, fast forward 10 years from now, we would have, just like NLST 20 years ago with Dr. Henschke's work, brought lung cancer screening to guidelines. We will collectively launch a trial that would be LDCT trial, not just lung, but not just cardiac, but a chest LDCT, which even so we say chest, liver is in there significantly. We've already shown the predictive value. So that's a direction that our group collectively is researching and working towards.
Very good. Dr. Naghavi, if you could maybe address, so we're talking about this great future of all these amazing technologies that we've got, and we'll be able to screen so much more efficiently and catch disease so much earlier. What are some of the challenges that you see to bringing AutoBMD AI and other tools like it to mass adoption?
Great question. You can imagine the first step is always education for our providers and patients, first providers, so they really realize that this value is there and they're able to act on it. I would say out of all these items that we have here, osteoporosis, as Dr. Atlas and Dr. Reeves said, low-hanging fruit, really low-hanging fruit, because the guidelines are out there. Everybody knows that bone density is an issue, bone loss is an issue. And, literally after age 30, everybody starts losing some level of bone loss, bone mass, some more accelerated than others. So we started with that. Even that is so widely known, we have problems communicating with practitioners that this information is there, and because their brain is just wired with one thing, DEXA. We just send people to DEXA, and they don't do enough job of that, and they're overburdened. So that's one part, education. And as Dr. Atlas said, a cardiologist is busy with lipids and related to stuff. He doesn't have a good, handle of osteoporosis management. That's also, so education and giving them the guidelines. And then the other part is the distribution channel. As you know, it's really difficult to get into the systems that are out there. That we're going like 2 years of trying to get a contract in place with these distribution companies to get this in front of PAC systems and different, outlets that radiologists have access to. So those two I would consider our major challenge. The good thing is, as I said, Medicare is already reimbursing this. They realize the value. They've just recently given us coverage for Category 3 coverage for cardiac chambers analysis. But just like anything else in medicine, we're very slow. You get a new iPhone, in a week, everybody knows how to use it. It takes us 100 times longer in medicine to get a new technology adopted and delivered to the mass. But we're hoping that with this approach, as Dr. Yankelevitz said, opportunistic is a word that is very easy to get it. It's a no-brainer. You've got this scan, you've got the patient going through, just click, just like Dr. Atlas said, 2 clicks, you get the report. But those are challenges that hinder our progress.
Yeah. Dr. Atlas, you're a provider as a radiologist there. What sort of challenges do you see in having technology like this adopted more widely at practices like yours and other practices outside of radiology?
I think it's been touched on mostly, but I guess the key 3 is, education, time, and money. The education we talked about. The time thing we also kind of went through, but it's just, I think any new technology can't result in the doctor having to spend more time. And a lot of the tools that come out, they use time, but they don't generate any revenue in it. No one uses them, So I think that's the key. I think AutoBMD has achieved that with not taking up any extra time and not requiring, say, the cardiologist to fully understand the intricacies of, working up osteoporosis. It's very self-explanatory on a nice color report. They just have to agree to it, basically. And then for the money, it's just the bottom line. Most people don't have a lot of extra money. And in general, they're worried about any kind of expensive test, particularly if it's not going to be covered. So I think that's been solved to some extent because AutoBMD is covered. Insurance covers it. And it saves everybody a lot of money because the traditional system, you'd have to have, at least at a lot of places, you see your family doc who then refers you to endocrine, who does another evaluation, then has to write the script to the DEXA scanner. And I think people just drop out along the way. Either the deductible gets too high or an appointment comes up. So I think that's why you got to do it right when they're there. If they're at the scanner getting a test done, just do everything you can before they leave. I think that's the key.
Yeah. Well, this has all been, really interesting. It's a really exciting future that we have in front of us, and it's based on a lot of the research that it's been done already. But it's the way that it's being applied. It's really going to be exciting to see where this goes. So I'd like to thank Dr. Morteza Naghavi, Dr. David Yankelevitz, Dr. Claudia Henschke, Dr. Thomas Atlas, and Dr. Anthony Reeves for being with us today. It's really been a pleasure talking about this new technology. Thanks to everybody.
Thanks for having us.
Thanks. Good seeing you.
Bye-bye.
Bye.
All right, signing off for the Imaging Wire. My name is Brian Casey.